I'm Ruth Biller from ARVC Selbsthilfe Germany, a patient association for patients with arrhythmogenic cardiomyopathy, and I'm also chair of the European Patient Advocacy Group of the European Reference Network for Rare Heart Diseases, Ear and Guard Heart. And today I'm talking to you about Desmoplakin-Kardiomyopathy and the new risk score. So what is Desmoplakin-Kardiomyopathy? It's a cardiomyopathy which is caused by a genetic variant in a desmoplakin gene, or called also DSP gene. So DSP variants can cause arrhythmogenic right ventricular cardiomyopathy, ARVC, but also left dominant forms, ALVC, biventricular forms affecting both ventricles, ACM, arrhythmogenic cardiomyopathy, and also non-dilated left ventricular cardiomyopathy, NDLVC, and DCM dilated cardiomyopathy. The most important thing to know about DSP is that it can cause sudden cardiac death in the young. And unfortunately, this can be the first symptom in the family. It can also cause myokarditis. The myokarditis-like hot phases are when patients experience breast pain, tachycardia, arrhythmia, palpitations, and it's sometimes diagnosed as myokarditis. Also, the underlying cause is a deep DSP cardiomyopathy. It can also cause atrial fibrillation because it can also affect the atria of the heart, not only the ventricles. And the interesting thing is that it can also affect the skin and the hair. So if you see a patient with woolly, very curly hair and with palmoplantar keratoderma, which means the severe callus on the soles and palms of the feet and hand, then you should be aware that it could be a desmoplakin cardiomyopathy. So in our patient community, we see quite a lot of patients under and misdiagnosed. So there are frequent pitfalls. The first thing is that the family history is not taken. So please ask for sudden cardiac death, sudden cardiac arrest, myokarditis in the family. If there is any other family member experiencing heart symptoms, there any other family member who has an ICD or a pacemaker implanted, anyone who takes beta blockers without suffering from hypertension, and please look out for the skin and hair characteristics. The next pitfall is the gene test. There are sometimes deletions and duplications in the DSP gene, and they are overlooked in a pure next generation sequencing gene panel. So therefore, you should always perform a copy number variation analysis if you suspect a DSP cardiomyopathy. Then, if someone has atrial fibrillation, it should raise suspicion of DSP cardiomyopathy if the patient is very young or if there is a family history of heart disease like above. So then a gene test should be performed. And most importantly, if you have a patient with myokarditis, it should raise suspicion of DSP cardiomyopathy if the myokarditis is virus negative, so if no virus is found, if it's recurrent, if it comes back, or if there is, like mentioned, a family history of heart disease. So please also then do a gene test. I want to present you a case of a young woman. She's now 31, but in 2016 she was 23, and the arrhythmia started, and cardiologist suspected a myokarditis. She did no sports for 1.5 years. And in 2018, there was a routine check, and the cardiologist told her everything was fine, and she got permission to exercise again. But then she experienced a cardiac arrest in the gym. Again, the diagnosis was myokarditis. She got an ICD and beta blockers. She got 2 times the cardiac arrest, ICD shocks, ablations, lead revision, so nearly everything a patient can experience in cardiology. In 2019, she writes a book, My Speed Dating with Death, about her experiences with her cardiac arrests. In 2020, the arrhythmia gets worse. She gets immunotherapy and immunoabsorption in an expert center for myocarditis. But then she has a new cardiologist, and this one finally recommends genetic testing. And, surprise, surprise, the diagnosis is a DSP cardiomyopathy, a left-dominant arrhythmogenic cardiomyopathy, and this happens 5 years after the first symptoms, which is far too late. But the hospital where she's cared of still denies the association of the genotype and the phenotype because the ARVC task force criteria are not met. So she has again an ablation, 6 ICD shocks with full consciousness. She has a lead extraction, a new ICD, and then atrial tachycardia at about 120 beats per minute, which the hospital declares as being benign because it's only atrial. But then we transferred her to an expert center, and there she was listed in high urgency for a heart transplant, which was performed after 6 weeks because her heart was completely, kaput. In 2024, she wrote a book, Your Heart, My Heart, about her experiences of being misdiagnosed so long and of her heart transplant. You can also look up this case at Westphal et al. In Gene in 2022. So, first of all, I want to talk to you about the old established ARVC risk score. The parameters there included are male sex, a history of non-sustained ventricular tachycardia, the 24-hour burden of PVCs, so the count of extra beats, the right ventricular ejection fraction in the MRI with an increasing risk the lower the right RVEF is, and other parameters like age at diagnosis, history of cardiac syncope below 6 months, and the number of inward T waves. But this risk score had a poor risk prediction in DSP cardiomyopathy and other left-dominant arrhythmogenic cardiomyopathy patients. So now we have a new DSP risk score, and there are a bit other parameters included, but also same parameters as in the ARVC risk score. The parameters were derived from the DSP registry of the Desperados network, which I think is a very nice name, where 26 institutions from 9 countries participate. Not surprising to me, the sex, here we have a higher risk in female patients. Like in ARVC, we have the history of non-sustained ventricular tachycardia, less than 30 seconds at 100 beats per minute. We have the 24-hour PVC count. But here we have the left ventricular ejection fraction, and the risk is already higher below LVEF below 50%. Late gadolinium enhancement in the MRI is not included because the lack of data, and also the LGE correlated with the left ventricular ejection fraction. And the fifth parameter is the moderate to severe right ventricular dysfunction. This can be measured in MRI with a RVEF below 40% or in the echocardiography with right ventricular fractional area change below 33%. So this DSP risk score was recently published this summer. So now we have a risk stratification with the DSP risk score, and in the end, we get a 5-year risk for sustained ventricular arrhythmia, VA, meaning sustained ventricular tachycardia, more than 30 seconds at 100 beats per minute. ventricular flutter or ventricular fibrillation, sudden cardiac arrest or sudden cardiac death, or appropriate ICD interventions, meaning ICD shock or an ATP for a sustained ventricular tachycardia. Now we have 3 risk groups: a low risk group, below 5% risk for VA at 5 years. Here, the decision for an ICD implantation may be withheld or deferred. In the intermediate risk group, between 5 to 20% VA risk at 5 years, an ICD implantation may be reasonable and may be discussed with the patient. And in the high risk group, more than 20% VA risk at 5 years, an ICD implantation is strongly recommended. So now we can do shared decision making with the DSP risk score. We have now a tool at hand with a very individualized risk tool, and the shared decision making between clinicians, geneticists, and patients may depend on age and sex of the patients, of the lifestyle or the cultural background, for example, religion and others. Interestingly, no DSP patients who was determined to be low risk had a sustained ventricular arrhythmia event after 5 years. So in this low risk group, you can be pretty sure that nothing will happen. But it's necessary to have a re-evaluation periodically because, as you all know, the risk of the cardiomyopathy may increase over time. There are a few limitations. The patients in the cohort were predominantly white, so you may not be able to extrapolate to other racial and ethnic background. The risk may be overestimated due to the cohort because the patients were followed up in expert centers, and events may have been missed due to dropout of patients before an event happened. There may additional risk factors exist which we don't know yet, and the family history of sudden cardiac death was not systematically collected, and this could be another risk factor. Well, this is my daughter Judith. She died of DSP cardiomyopathy, and I'm really happy that other DSP patients now know much more about the disease than was known in 2011, and that they have a risk tool at hand and they can decide on their life and if they want an ICD or not. And that's good news for all DSP patients and DSP carriers. Now, I thank you for your attention, and I thank Juan Jimeno, who has invited me. And this photo is taken at the ER board meeting in Amsterdam in 2023. And I'm looking forward to meeting Juan again at the next board meeting. And now have a good symposium and see you.